Welcome to the Lymphoma Research Foundation's Caregiving for a Loved One with Lymphoma webinar. I'm Jessica, and I'll be the operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Hope Avalone. Hope Avalone is a program manager of patient education at the Lymphoma Research Foundation. Welcome, Hope.
Thank you, and thank you to each of you for joining us on today's Caregiving for a Loved One with Lymphoma webinar. We'd first like to thank our sponsors of this webinar, AstraZeneca, Pharmacyclics, and Seattle Genetics. And before I turn the program over to our speaker, I did want to briefly share some information with you on the Lymphoma Research Foundation. We know that access to expert disease information is so important, and so we're thrilled to be able to bring you this educational program today. The Lymphoma Research Foundation, or LRF, is the nation's largest nonprofit organization devoted exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. And as we continue to make progress in advancing lymphoma research, we also want to ensure that as a caregiver, you have access to the latest information about your loved one's disease and the resources available to them. LRF provides comprehensive disease and treatment-specific resources, programs, and services for both patients and caregivers alike, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a wide variety of lymphoma-specific resources, all of which you can access via LRF's website at lymphoma.org. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant caregiver resources. And we also offer the Lymphoma Support Network, or LSN, which is a one-to-one peer support program for people with lymphoma and caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who might have similar experience to them to help give others strength to meet the challenges they might have to face during this time. And we also offer a variety of publications that have been reviewed by lymphoma experts to ensure that you have access to the latest lymphoma information, including information on various special topics, for example, a dedicated fact sheet for caregivers that is accessible at the bottom of your screen. And LRF also has created a lymphoma care plan to help guide patients, caregivers, and their physicians in discussing and documenting the cancer experience, and that is also available at the bottom of your screen. And lastly, we have comprehensive books on understanding non-Hodgkin lymphoma, Hodgkin lymphoma, and chronic lymphocytic leukemia for you and your loved one, and those can all be accessed at lymphoma.org. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your loved one's disease. And that app is available for free for download in the Apple App Store and in Google Play, and I would encourage you all to download that today. And we will also be hosting our largest program, our North American Educational Forum on Lymphoma and CLL, and that is virtually this October. And this 2.5-day program will include a wide range of disease-specific and supportive care topics, and it will include a caregiver support group as well. So to learn more about any of these resources and programs, or if you have any questions regarding what you hear today on this webinar, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. We do hope that you will take advantage of some of these great resources and services, and we have a wonderful program planned for you today. So I'm honored to finally introduce Dr. Christopher Flowers. Dr. Flowers is a hematologist and oncologist at the University of Texas MD Anderson Cancer Center, where he's also a professor and the chair of the Department of Lymphoma and Myeloma. Thank you so much, Dr. Flowers, for speaking on our program today, and I will now turn the talk over to you.
Well, great. Thanks so much, Hope. I really appreciate that introduction, and I appreciate all of you joining us today. Really want to make some quick comments to reinforce some of the incredible resources that Hope just described. For any of those types of resources that you're interested in, I would recommend that you go to the lymphoma.org website to identify and find out more information about those resources, and in particular, the Focus on Lymphoma app that you can download. As someone who has worked in medical oncology for a number of decades now, that truly is the best app that is out there that's available to patients and caregivers as a resource for lymphoma, but really stands as a great hallmark for a resource across all cancers. So it's my great pleasure today to talk to you as caregivers about how to provide caregiving for a loved one with lymphoma. And there are additional areas that I'll touch upon that would be relevant for those of you who are patients. And as Hope mentioned, I'm the chair and professor of the Department of Lymphoma and Myeloma, but also hold an additional role as the division head at interim, where I oversee all of cancer medicine at MD Anderson. So these are my roles that as they relate to companies in terms of disclosures. I've served as a consultant for a number of companies, predominantly related to my role in developing clinical trials for lymphoma, and received research funding, which is predominantly in my role as division head, where I oversee all of medical oncology and oversee research funding for alliances between companies and MD Anderson. But also have grants from the National Cancer Institute and the Cancer Prevention Research Institute of Texas that support my work in lymphoma. So what I'll spend most of the time today is providing an overview of lymphoma, ways of communication with the health care team, ways for managing stress and coping as a caregiver, and some practical tips throughout for caregivers, and spend plenty of time for questions and answers at the end. So one of the things that all of you are obviously very familiar with are the new challenges that we face in healthcare now in the face of the COVID-19 pandemic. There obviously have been changes that occur on the very local level related to local COVID prevalence in the community, changes in terms of the ways that it's affect patients and their caregivers' abilities to be able to get to particular cancer centers in terms of the ability to travel, and to be ability to have referrals expeditiously, particularly to academic medical centers, and the need to have clear reminders about safety around COVID-19. Some of the things that we did relatively early on in COVID-19 really led the way in terms of the way lymphoma patients and their caregivers were engaged from the standpoint of the pandemic. We changed our entry screening levels for patients coming into buildings, instituted universal masking and social distancing in all areas of our building, with specialized masking and face shields for special areas that were parts of our facility that allowed patients who were COVID positive, whereas the vast majority of our facility does not allow COVID positive patients to enter those spaces. And we also have coordinated scheduling of follow-up in patients, focusing on our local patients here in Houston versus those who come from the other 49 states. And then conducted telehealth visits, which has become much more prominent in care planning, and placed an emphasis on the goals of care in all of our care planning, with an early reopening of clinical trials for our lymphoma patients specifically, to provide the most specialized care. Given the range of clinical trials and the ways that patients with lymphomas can benefit from clinical trials, really our clinical trials closed for just a couple of weeks in the early phase of the pandemic, and our lymphoma clinical trials were the very first of those to open. These are just examples that are emblematic of the ways that COVID-19 has been managed across all the institutions that all of you are associated with, and things that I think affect the ways both that patients and caregivers need to interact. very early on in the pandemic, we had very limited ability for caregivers to be engaged, particularly on the inpatient side with patients, and have had to adapt to some of those changes over time in terms of our care planning. One of the things that we kept as central to that, and some of this slide is cut off, is to be able to make sure that innovative medical therapies were delivered in a respectful and patient-centric manner to all of our patients, and that included some of these virtual environments. And this shows an example patient who was having a visit on her iPad to her physician, that it was engaging with her as a way of being able to keep her safe from travel. This has also involved caregivers. This just shows another example of a virtual visit that occurred through remote care very early on in the pandemic, where we're utilizing proactive monitoring in the home. It's a little bit difficult to see, but the patient to the right actually has an armband that has a patient monitor to help to improve connectivity with our patients in their homes, help to ultimately prevent urgent and emergent admissions, to be able to intervene before symptoms arise, and to hopefully provide better quality of life for patients and for their caregivers, and reduce stress in terms of patients who need to come to our acute care center. These are yet other examples of the ways that the COVID-19 pandemic has affected the ways that we deliver care to patients in this setting. And these have important roles for caregivers. I think as we think about how do caregivers play a role in our remote care process, I think it's important to think about the support roles in terms of helping with connectivity between the healthcare system and your loved one. Some of those can include areas around some of the technical challenges that occur, like having access to a laptop or to a iPad with a video camera to be able to have those interactions. Others include some of the social support that's needed to be able to engage in remote care visits. The same kind of social support that's needed in an in-person visit is also needed there, as well as having that emotional support that is key to providing care in the remote care environment as well. Likewise, remote care visits require coordination, kind of very similar to an in-person visit. Just the same way that someone's going to need a ride to clinic or arrange transportation, sometimes even needing to arrange flights back and forth if it's a distant site that you're receiving your care. Those same kinds of coordination are needed for remote care visits as well, including the technical and social support there. And as a caregiver, that's a place where you can definitely help. It's also important to help in defining the clear roles and goals for a remote care visit. One is the remote care setting, an appropriate one for a remote care visit. If this is a visit to do things like decide what inpatient therapy is necessary next, and coordinating an inpatient visit after that. Sometimes that might be more appropriate in person than a remote care visit. Things like review of scans, where the thought might be a long discussion that involves additional physical exam or other characteristics to coordinate the care, may not be quite as appropriate for a remote care visit. And then also understanding how those can influence timely care and quality of life, both for the patient. And you as a caregiver can really help in that process. So in the next set of slides, I'm going to really go through Lymphoma 101, kind of everything you may want to ask about lymphoma, but we're afraid to ask. So one of the most common questions that comes up in the setting of a clinic is, how did I get lymphoma? And lymphoma is overall, the collection of lymphomas are the most common blood cancer as a collective. For the vast majority of lymphomas, the cause is unknown. I have been a member for the last couple of decades of a group called InterLymph, or the International Lymphoma Epidemiology Society. That's a group of hundreds of researchers. We actually had our virtual meeting just a couple of weeks ago. Hundreds of researchers who are from across the world who have gathered together to put together tens of thousands and now bordering on hundreds of thousands of patients across the world to be able to understand what are the factors that lead people to get lymphoma. You don't really hear about groups like this in breast cancer or in colon cancer or in lung cancer getting together to be able to study the causes of those cancers, because the causes of those cancers are much better well known and were easier to describe. Because the lymphomas are rarer and have more specific subtypes, it's required groups like that to be able to understand the causes of lymphoma. We do know some of those risk factors, but for the vast majority of people who get lymphoma, the causes are known. Having a family history of lymphoma or another blood cancer is one of those risk factors. Having an autoimmune disease of any type, particularly those that are more associated with B-cell mediated autoimmune diseases, can be associated with B-cell lymphomas, and those that tend to be more associated with T-cell autoimmune mediated diseases can be associated with both B-cell and T-cell disease. Having had a solid organ transplant is associated with a particular kind of lymphoma that's called post-transplant lymphoproliferative disorder, or PTLD. Specific exposures to certain chemicals and pesticides, but generally those are exposures that are at very high levels. In the cases of pesticides, it's usually not individuals who are using pesticides to spray their garden or other kinds of usual use that we would have in the home or a recreational environment, but exposures that can occur if, for instance, if you were a field worker and working in a field where the field was being crop dusted on a regular basis, and that high level of exposure, or working in a pesticide plant. And then also exposure to certain infections. Some examples of those are Epstein-Barr virus, or EBV. That's also the virus that causes mono. And so there clearly are many, many more people who get EBV and get mono than there are people that get a lymphoma. HIV has also been associated, hepatitis C, and Helicobacter pylori has been a bacteria that's been associated with that. One of our faculty member who is trained both in infectious disease and in lymphoma has a particular area of specialization looking at these kinds of relationships. The second major question that comes up is, what is lymphoma? And really the schematic to the right shows a mannequin of the human body where those green lines that are shown through are tubes of lymph, where the lymph system is a circulating system through the body, very similar to the way the blood circulates. And through that lymph system, there are also stations that are lymph nodes. Lymph nodes are the kind of thing that you can commonly feel in your neck or under your arm when you get an infection that's relatively close to the skin, or get a sore throat, that sometimes those lymph nodes in the neck will swell and you can feel those. But those exist in stations all throughout your body, both in those areas that you can feel that I just described, but also in many, many more stations that are deep inside of the body, deep inside of the chest or inside of the abdomen. And those are the areas where lymphoma comes from. This is also a system that is connected to the spleen, which is an organ that sits under the left side of the rib cage, and also connected to the bone marrow, which is a part of the blood system that is inside of the bones. There are two major types of lymphoma, the B-cell lymphomas that I mentioned and the T-cell lymphomas. These are both kinds of white blood cells that circulate through the blood. And as these cells grow and mature, something can go wrong with that process in the cellular genetics, causing a lymphoma to occur. And depending on where the lymphoma arises and what kind of lymphoma subtype, that determines the type of lymphoma that's involved here. The other thing that comes up commonly is how lymphomas are different from leukemias. Leukemia, or a blood cancer, is a cancer of the blood that typically starts in the bone marrow and arises from stem cells that circulate in the blood, whereas the lymphomas tend to occur from what we call something around the mid-growth cycle in the development of the blood system, and commonly can occur in the lymph nodes or in other spaces. The other two major categories have been called Hodgkin's lymphoma or non-Hodgkin's lymphoma historically. In more recent years, we've actually dropped the apostrophe S, in that we're trying to remove the cancers or other diseases that are eponyms or named after a different after an individual. And so the more technical correct terms now are Hodgkin lymphoma and non-Hodgkin lymphoma. Is two major classifications of the lymphomas, where Hodgkin is named after Dr. Hodgkin, who first discovered the disease, and arises from an abnormal set of cells called Reed-Sternberg cells. And there are 5 subtypes there. Non-Hodgkin lymphoma is not a disease, and that's something I really strongly reinforce with all of our trainees, but it's a category of diseases. There are many subtypes of lymphomas. This slide here that comes from our work that we led with the American Cancer Society and the National Cancer Institute really was the first time in 2016 where we described in the United States each of the different subtypes of lymphomas using the World Health Organization classification. I mentioned that there are at least 65 different subtypes of lymphomas, or the non-Hodgkin lymphomas. There are likely very soon to be even more subtypes, as the World Health Organization is in the process of putting out their newest classification system for 2022, where we'll have even more subtypes that are named. But you can see shown here the lymphomas shown in the dark blue pie chart, pie component to the bottom. A diffuse large B-cell lymphoma, or DLBCL, is the most common type of non-Hodgkin lymphoma, accounting for about 27,000 individuals who are diagnosed with that each year. I think it's important to think about that in comparison to the gray pie chart that is to the left, which is plasma cell neoplasms or multiple myeloma, where you can see that that one subtype of lymphoma, diffuse large B-cell lymphoma, is actually more common than all of multiple myeloma. And you can see many of the other non-Hodgkin lymphoma subtypes that are shown there in this pie chart. And happy to take questions about any of those as things progress. Why are there so many subtypes? Part of that is because a lymph node is comprised of many parts, and I'll show you that in the next slide. And depending on where the cancer originates in the lymph node can determine the name or type of the lymphoma. So this just shows an example of a lymph node cut in cross section. So if you think about those lymph nodes that I showed you in that first mannequin of the body, those are stations throughout the body, and those are typically bean shaped in origin. And this is an example of one of those cut in cross section, and then colors are supplied here to be able to name those different parts of the lymph node. So you can see shown to the left of the slide, there's a description of that largest red structure, which is called the primary follicle within the lymph node. That's where follicular lymphomas come from. The majority of lymphomas come from that germinal center that is part of the follicle. You can see in the middle of the slide shown on the darker red portion around the follicle, a description of the mantle zone. That's where mantle cell lymphomas come from. You can also see that the marginal zone is described here as part of the lymph node. That's where marginal zone lymphomas come from. And various other lymphoma subtypes come from other components of the lymph node. So what are the major symptoms that we think of for someone who's diagnosed with lymphoma? Sometimes there could be no symptoms at all at diagnosis. Some of the common symptoms that can occur when they do occur are painless swelling of the lymph nodes, either in the neck or under the arm or in the groin, or sometimes in an area like around the eye, where it's visible or affects the body in certain ways. Sometimes these can be painless swellings deep inside of the body, where those are not easily noticed. These lymph nodes are usually fairly movable and non-tender. Occasionally, there can be unexplained fevers that are associated with it. There can be night sweats, and so this is sweating at night that occurs without any particular cause or infection other than the lymphoma. And there can sometimes be unexplained weight loss that is over 10% of the body weight. When those last three symptoms occur, fever, night sweats, and weight loss, those are so-called B symptoms that have been associated with lymphomas. Other symptoms that can occur, this is an unusual symptom that sometimes occurs and occurs more commonly with Hodgkin lymphoma, is that people may have pain at an involved site after drinking alcohol with involved lymph node. Itchy skin can occur, although there are obviously many more causes of itchiness that are not associated with lymphoma. Reddening patches of the skin and prolonged and constant fatigue is another symptom that can occur. So how is lymphoma diagnosed? Really, the major components of that are performing a comprehensive medical history, doing a thorough physical exam, examining all those lymph node areas that I described, doing laboratory workup, including blood counts, like a complete blood count or CBC, doing a comprehensive metabolic panel or CMP that tells about liver function, kidney function, and other organ function. And a particular test called the lactate dehydrogenase, or LDH. LDH is a factor that's associated with several lymphomas where when it is elevated, that is a poor risk factor in terms of the patients who have that factor elevated tend to have worse outcomes with standard therapies. The key component for making a diagnosis of lymphoma is a lymph node biopsy. Historically, that has been an excisional lymph node biopsy. That means either taking out the entire lymph node or taking out a big enough chunk of the lymph node using surgery to be able to review that under the microscope. Now, more commonly, that is done by an interventional radiologist, where that's done using a core needle biopsy, and multiple core needle biopsies are needed to get that same level of tissue to be able to examine under the microscope. The additional process of staging occurs using either CT scans of the chest, abdomen, and pelvis, or a whole body PET CT scan that gives information both on the location of the lymph nodes and the activity of the lymph nodes. And bone marrow aspiration and biopsy is typically done. We're taking a needle about the size of the tip of a pin and placing it into the hip bone and taking back some fluid and tissue to determine what's going on inside of the bone marrow space is often helpful to make a lymphoma diagnosis. So what are the key roles for a caregiver in the process of making a lymphoma diagnosis? Again, providing emotional support for your loved ones is essential in this component. This is also a key time for having an extra set of ears. Oftentimes when someone hears a diagnosis of lymphoma or hears a diagnosis that they now have a cancer, they really do not hear anything else that's said in that visit after that time. And that's where a caregiver can be absolutely critical to helping to understand the diagnosis and understand the next steps in the care process. The other thing is, just as we have a medical team that's involved in the care plan, including physicians, advanced practice providers like nurse practitioners and physician's assistants, nurses, pharmacists, infusion center nurses, care coordinators, and on and on and on, you should also have a team on your side of things as a caregiver. And identifying who those individuals, I think one of the things that patients often get barraged with after that someone hears that they have a diagnosis of cancer is that there's an outpouring of the community, of family and friends, of people who want to help. And your role as a caregiver can be the one that helps them understand how they can help. You'll need particular individuals like a chief note taker who's there for the visits to be able to keep track of all the things that need to be done. Folks that help as a transportation coordinator to and from clinic visits or any of those testing or any of the treatment that I'll talk about next. It also is useful to have caregivers who are involved as the communication hub so that the patient is not the person who needs to answer every single call about how are you doing, what are you doing next, did they check this, are they thinking about that, that you as a caregiver or someone you designate really serves as that communication hub and who helps to manage that telephone tree of all the people that care about you and want to help your loved one as a patient. And then as a caregiver, you can also really help to clarify the key next steps and timelines. One of my patients whose family member really did the best that I've ever seen as a team, call her a coach for her team of caregivers, really designated herself as the chief note taker. She was at every visit with her husband and helped to manage through that process. He had a bunch of college buddies, many of whom who had not seen him for years. They were his transportation to and from all of his chemotherapy visits for his 6 cycles of chemotherapy, and then all the follow-up care that he needed after that, as well as his maintenance therapy. She designated another aunt who liked to communicate as the communication hub. And so whenever anything happened at the clinic visit, the aunt was there. And then the patient's wife communicated with her in terms of what the things were that happened at that visit and what the next steps were. And anybody in the family or friends or anybody who was not connected did not call the patient, did not call the patient's wife. They called the aunt for anything that needed to happen, needed to be communicated about the care plan. And so I think defining the team roles as a caregiver really can be an effective way to help your patient and your loved one. Next, I'll turn to talking a little bit about the staging process. Staging for lymphoma really refers to the extent of the disease based on the number of effective lymph nodes areas that are involved and the locations of those lymph nodes. So we call lymphoma a stage 1 disease when there's a single lymph node or a single lymph node area that all fits inside of one radiation field, stage 1. When there are 2 or more lymph nodes on the same side of the diaphragm or the same half of the body, we call that stage 2 disease. And again, you see the mannequin to the right with roughly where the diaphragm is dividing the body in half. And so if you see all of those lymph nodes on the same side, we'd call that stage 2. We call it stage 3 disease when there's disease on both sides of the diaphragm. And we call it stage 4 disease when there's evidence of the disease outside of the bone marrow, outside of the lymph nodes into the bone marrow or spleen or other organs, such as the liver or other regions. I think one of the things that's also very important to know about the lymphomas, it's very different than solid tumors. We commonly think of solid tumors when they're stage 4 disease as metastatic cancer, instead of metastatic cancer that is not curable, typically when it's stage 4 disease. For many lymphomas that are curable lymphomas, that they are curable even when there's advanced stage disease, even when there's stage 3 or stage 4 disease, the goals of treatment can still be cured. Many lymphomas also present with advanced stage disease because they're because patients don't have symptoms at the time when they're first diagnosed. And so we very commonly see patients with stage 3 and stage 4 disease when they're diagnosed, which is also a little bit different than many solid tumors. So what's next after the staging? Typically additional tests may be ordered to look at organ function, sometimes to look at things like heart function using an echocardiogram or a specialized lung function test. And the physician and the team will meet with the patient and their family to discuss the diagnosis and all test results, and then to move forward with a treatment plan. So what are the key roles for a caregiver in the evaluation process? The key really here is to help to be clear on what the next steps are, what the timelines are, and what the goals of therapy are based on the stage, based on what the patient's performance status is, and meaning how well they're doing functionally, independent of the cancer, and how well their organs are functioning based on all the other testing that I just mentioned. It's important to be able to understand the process involved in evaluation, and having an extra set of ears here for the patient is important as well. This is also a key role, is collecting all the data that are needed from various sources, particularly if this initial evaluation leads to additional evaluations with visits to a subspecialist or to another center. Having all those data points available from various sources is really critical. And then helping your loved one to discuss all these evaluations with others using that communication hub that I just mentioned. So the next stage process that I'll talk about in very broad terms is how you treat lymphomas. The treatments of lymphomas differ quite dramatically across non-Hodgkin lymphoma subtypes and across Hodgkin lymphoma. And so I'm not going to talk about any specific treatments. If there are specific treatment questions, I'm happy to take some of those in the question and answer session. But these can vary from things like watchful waiting that can include observation after a diagnosis is made for some period of time. The longest time that I've seen a patient observed, for instance, a patient with follicular lymphoma, where that's a common approach at diagnosis, is I had a patient that went 14 years before he needed to have some sort of treatment. And so that watchful waiting period can be long for some patients. Single agent chemotherapy is sometimes a treatment. Combinations of chemotherapy, particularly chemotherapies with a form of immunotherapy like rituximab, can be an approach. Clinical trials are something that I think that is important to consider both at diagnosis and if lymphoma comes back. Radiation therapy can sometimes be an important role for patients with lymphoma, given that lymphomas are very sensitive to radiation therapy and can often be wiped out with radiation in the spots that are radiated. And there are a host of biological therapies, transplantation for patients who have their disease come back, as well as novel therapies like cellular therapies and chimeric antigen receptor T cells or CAR T cell therapy. So I think the other things to consider during the process of treatment are the social determinants of health in terms of the ways that living conditions, behaviors, and other factors may affect health outcomes. And I think those are the kinds of things that we as care providers take into account, and places where a caregiver can help to intervene in those factors where it can make a difference for patients' outcomes. So some of the key roles for caregivers here are, again, to be able to provide some of the emotional support and an extra set of ears, particularly in the treatment process as it relates to the expected outcomes, and helping to communicate that back and forth with your patient loved one, and other family members in terms of what the plans and expectations are for outcomes of the treatment. But also communicating back and forth about side effects and between the patient and the care team, and ways to be able to address those side effects. The coordination of the team roles also is important in the treatment process, and helping to clarify the next key steps in terms of the treatments, things like cycles of treatment, when the next cycle is due, what the timelines are for that, and what the goals are with each step of the therapy in terms of when restaging will occur and other kinds of things. The last thing that I will turn to is the role that research plays. And I've been very fortunate in my role as chair and a professor at MD Anderson to work with a fantastic team of individuals, but all academic medical centers have teams of individuals that are focused on lymphomas, as do many community-based practices. Within my group, we have individuals like Dr. Nastapol, who's been a national leader in the first in human studies and the care of patients with indolent non-Hodgkin's lymphomas, Dr. Weston, who focuses on the aggressive lymphomas, Michael Wong, who focuses on mantle cell lymphoma, Satva Nilapu, who's been a leader in CAR T cell therapy, and Michael Green, who's a leader in translational research. And these just show examples of the kinds of research that we do. Here is work from Dr. Nastapol, where we've had large observational studies of lymphoma patients involving thousands of patients with lymphomas. This slide got a little bit garbled in moving into this format, but what you can see here is that across that we've been able to study patients across different categories, and to be able to look at outcomes for different patient populations. Likewise, Dr. Green has led our work in translational research, where we've been able to take samples from patients and to be able to create what are called patient-derived xenograft models. These are models of lymphoma tumors that we can grow in mouse models to be able to understand new drugs and new therapies like CAR T cell therapy that we first tested in these models for proof of concept, and then eventually translated work like that to patients, and can do many, many more tests to be able to understand the data that come from these models. And so when we think about the roles that clinical trials play for patients with lymphomas, these are concepts that are vetted by principal investigators at each site. In our group, those disease section leaders that I'd mentioned also help to supervise those trials to describe what the most important concepts are to move forward. They're reviewed and voted on at our lymphoma and myeloma research meetings, and then ultimately submitted to a committee in our group, like a scientific review committee that reviews all of our clinical trials before deciding these are trials that are worth moving forward with and ultimately enrolling patients on. And so as we think about the roles that a care provider might play in the research process, I think it's important to learn about what clinical and translational research opportunities are available in the locations where your loved one is getting care, to be able to understand what the expectations are for the risks associated with the clinical trial, what the potential benefits of participation are, understanding the roles that data collection, testing, and clinical trials and treatment may play in the care process, and to be able to support research participation where possible. I think it's the community of patients and caregivers and physicians who've been involved in lymphoma research and groups like the LRF that have led this area that really have made tremendous advances in the field over the last couple of decades and have really changed outcomes for patients with lymphoma because of that investment and focus on research. So finally, just to conclude with some tips for successful caregiving, I think it's really important to support the communication that you have back and forth with the healthcare team, to be able to manage stress for yourself and for your loved ones. And at this point, I'm happy to take any questions and answer those.
Thank you so much, Dr. Flowers, for your excellent presentation. And like you said, we're just going to move into the Q&A portion of the program. So if anyone has any questions, please make sure to submit those through the Q&A box on your screen. And we'll take as many as possible. But if you have a question that doesn't get answered, you can always reach out to the Lymphoma Research Foundation's helpline. And that number is 800-500-9976. But in the meantime, let's get started with our first question. So this first patient writes, I was diagnosed with CLL. My doctor said I am stage 1, so he's not starting me on any medication. What are the signs when I need to start treatment?
That's really a great question. So I mentioned that watchful waiting is appropriate for follicular lymphoma. CLL is another disease where watchful waiting is an important part of the management strategy. Typically, those signs or features that are associated with that, in CLL in particular, we can sometimes see if the lymphocytes or the CLL white blood cells start doubling more rapidly, then that can be a sign that it's time to start treatment sooner rather than later. Having symptoms that are associated with the CLL, so any of those symptoms that I mentioned, fevers, night sweats, weight loss, those can be symptoms that can be signs that it's time to start treatment. Occasionally getting bulky lymph nodes, so large lymph nodes in the neck or under the arm or in the groin that are causing discomfort. Those can be other kinds of signs and symptoms. And there are a whole laundry list of others as well, but those are really the main ones and the most common ones that lead someone to get started on treatment.
Thank you, Dr. Flowers. And the next question is, my wife's oncologist says that my wife's NHL has the Richter's mutation, which is rumored to make to accelerate the cancer and to make the mortality prospects considerably worse. Would you be able to explain what the outlook might look like with this mutation?
Yeah, so there is kind of a very strict definition. So I'll give you the very strict definition, and then there's a looser definition that is commonly used. So Richter's transformation specifically refers to the transformation of CLL to diffuse large B-cell lymphoma. It's sometimes used more loosely as any transformation of a low-grade or indolent lymphoma to a more aggressive lymphoma, like from follicular lymphoma to diffuse large B-cell lymphoma, or marginal zone lymphoma to diffuse large B-cell lymphoma. Those technically are not Richter's transformation, but that terminology has become more common. When we see that evidence of transformation, some of the concerns there are that that is a sign that there is both this aggressive variant of lymphoma that is present, like a diffuse large B-cell lymphoma, and still the indolent or slow-growing variant like CLL or follicular lymphoma. And when we see that, we shift towards the kinds of treatments that would be more appropriate for an aggressive lymphoma. Oftentimes, those would involve therapies like an anthracycline-based therapy, the most common of those being the R-CHOP regimen. That's a combination of rituximab, cyclophosphamide, adriamycin, vincristine, and prednisone. Uh, Sometimes patients cannot tolerate that, particularly older patients who have this evidence of transformation that occurs later on. And so we need to think about other kinds of regimens. But those are the main concerns, is that this is becoming a more aggressive variant, and that a more aggressive therapy is necessary.
Thank you so much, Dr. Flowers. And the next question is, for someone who caught mantle cell lymphoma in the first or second stage but are older, for example, 60 plus, what are the normal treatment option recommendations? Is the life expectancy long?
Yeah, so this is really a very difficult question to answer, because there's a lot of variability in the disease of mantle cell lymphoma. Mantle cell, I mentioned kind of in the last answer, the distinctions between an indolent lymphoma or low-grade, slow-growing lymphoma and an aggressive lymphoma. The challenge with mantle cell lymphoma is that it can sometimes behave like either. There are certain characteristics about it that we can look at. Some of those are molecular characteristics, like 17p deletion, or involvement or mutations in the TP53 that are associated with that. Others are clinical characteristics that are components of something that we call the Mantle Cell International Prognostic Index, or the MIPI factors. And those are factors that can predict how aggressive mantle cell lymphoma is behaving. On the aggressive end of the spectrum, there are combination chemoimmunotherapy regimens, like the one that my colleague Michael Wong helped to pioneer, that uses the hyper-CVAD regimen, that is a more aggressive regimen that has alternating cycles of chemotherapy. On the other end of the spectrum are approaches like the LRF board members Peter Martin and John Leonard from Cornell helped to pioneer, that even involve watchful waiting and more indolent approaches to mantle cell lymphoma. So it's a broad spectrum of diseases. The other things that have really changed therapy for mantle cell lymphoma are the use of the Bruton's tyrosine kinase inhibitors. And so the use of that class of agents really are something that provides a non-chemotherapy based approach for patients that is most commonly used when patients have their disease come back. So a whole spectrum of options. I didn't really answer your specific question directly, but for some patients who have that more indolent variant of mantle cell lymphoma, the survival can be very, very long. And even patients who have the more aggressive variant with aggressive treatment, survival can be quite long.
Thank you so much. And the next question is, can you explain the difference between chronic lymphocytic leukemia and lymphoma?
Yeah, so that's a very interesting question. So there really are two separate diseases that go by, or sorry, there's one disease that goes by two separate names. So we typically call this disease small lymphocytic lymphoma, or SLL, when we first find it in the lymph nodes. And we sometimes call it CLL, or chronic lymphocytic leukemia, when we first find it in the blood or the bone marrow. So that's just one example how one disease can go by two different names. CLL is typically a disease that's found in the blood or the bone marrow, whereas lymphomas are more commonly found in the lymph nodes as their starting place, or sometimes in the skin or a solid organ.
Okay, thank you. And for our next question, can you comment on the maturity and efficacy of CAR T therapies?
Yes, so CAR T cell therapies are treatments that are quite mature. Really, the first clinical trials that were done in CAR T cell therapies were done nearly 10 years ago now. Those are therapies that are now FDA approved in the relapse setting for both aggressive lymphomas like diffuse large B cell lymphoma and more indolent lymphomas like follicular lymphoma. We now have brand new approvals for CAR T cell therapies where CAR T cell therapy has directly taken on autologous stem cell transplantation for patients with diffuse large B cell lymphoma who've had early relapse of their disease, so had their disease come back within a year or progressed when they got their first therapy. And those trials, two trials, showed that CAR T cell lymphoma, CAR T cell therapy produced better outcomes for patients with diffuse large B cell lymphoma than autologous stem cell transplantation. There was a third kind of CAR T cell therapy that was used in the same kind of trial that did not show a benefit, and that has not received that same approval. But those are now very mature therapies that have been used at MD Anderson, we're about to do our 1,000th infusion of CAR T cell therapy in patients here in a couple of days. And so there are literally tens of thousands of patients who have received therapies like that.
Thank you so much. And our next question today is, can you comment on some major lasting side effects of some of the therapies you mentioned? And this person is specifically interested in blood clots from allogeneic transplants or neuropathy from certain drugs.
Yeah, I will describe this in maybe in general terms rather than getting too specific, because each of the therapies that are out there for lymphomas all have specific side effects for them. And I think as a caregiver, it's important to uh, ask questions about what those side effects are, know what to watch for in terms of those side effects, and to be able to help your loved one to monitor for those kinds of side effects. Some of those, some specific examples of that. So one of the therapies that I mentioned, vincristine, that is commonly a part of the R-CHOP regimen, is a kind of drug that can cause peripheral neuropathy, so tingling of the fingers or toes in its mildest form, and its more severe form, difficulty with weakness or motor function in some of the muscles. Uh, Other kinds of treatments, drugs like lenalidomide and other drugs can put individuals at risk for blood clots and other kinds of side effects like atrial fibrillation. So for every specific drug, it's important to know what the potential side effects are and how to monitor for those side effects.
Thank you so much. And this next caregiver writes in, they're wondering if there's any correlation between chronic lymphocytic leukemia and Hodgkin lymphoma. They say their daughter was diagnosed with Hodgkin lymphoma at age 32, and her mother-in-law, her grandmother, was diagnosed with chronic lymphocytic leukemia in her 60s.
Yeah, that's a great question. As I mentioned in the discussion of the epidemiology of the lymphomas, there is an association between the development or the risk of development of a lymphoma and a family history of blood cancer. Usually that is a direct relative, so a parent or sibling that has had a prior history of blood cancer, but we do also see that occasionally in families where there are more than one blood cancer involved. As of yet, there's not specific genetic testing or screening that can be done for the lymphomas. That is an intense area of my research. I actually work with a number of epidemiologists through the InterLymph and an epidemiologist here, Michelle Hildebrandt, who's focused her entire career on that. In terms of trying to understand what are the genetic risk factors for lymphomas, and can we eventually be able to develop some screening tests to help people who have a family history to know what their individual risk is.
Thank you so much, Dr. Flowers. And for our next question, can you describe the actual difference between PMBCL and DLBCL? My husband has PMBCL but is doing a lot of reading on DLBCL. Does DLBCL information always apply to PMBCL?
That's a great question. So when we look at that, diffuse large B-cell lymphoma, or DLBCL, as I mentioned, is the largest and most common type of lymphoma. Primary mediastinal B-cell lymphoma, or PMBCL, can sometimes be a difficult diagnosis to be able to distinguish from diffuse large B-cell lymphoma. We can see diffuse large B-cell lymphoma in the mediastinum, so in the middle of the chest. When it looks under the microscope like DLBCL, we should call it DLBCL. But sometimes the clinical characteristic that helps to distinguish PMBCL is that it's in exactly that area in the middle of the chest. There are some approaches to therapy that are distinct for PMBCLs. There is a regimen called the dose-adjusted R-EPOCH regimen that is more commonly used for PMBCL. Likewise, approaches like R-CHOP, that's commonly used for diffuse large B-cell lymphoma, can also be used for PMBCL with radiation sometimes as a component of that. And so there is a strong overlap between the two, but there is a little bit more specific literature on PMBCL and some therapies that need to be tailored towards that disease.
Okay, thank you. And if a patient comes into a practice and has no caregiver with them, do you strongly encourage them to find someone to fill that role?
If that's at all possible, I do strongly encourage identifying a caregiver, and that doesn't always have to be the same caregiver. I've seen many patients be successful with a team of caregivers that may be a spouse that works out of town or even works out of the country who's there for a period of time. Supplemented by friends and family who come in and out of town, or neighbors or others. But having a caregiver who can help for part of that care coordination that I described really is a key component. There are also health systems that help to supply individuals who can fill some of those roles when a caregiver is not always present.
All right, thank you. And we only have a few questions left here, but the next question is there any thought that Lyme disease can cause Hodgkin lymphoma?
So there have been questions about a number of infectious diseases that are associated with the lymphomas. Lyme disease is one of those that has been explored. That there have been evidence both to the positive and the negative that don't give us any clear conclusion about the association between Lyme disease and the development of lymphoma, but there are a few groups that are ongoing in terms of research in that area.
Thank you so much. And I believe this will probably be our last question for today. This person writes, can CLL make the immune system stop completely? My husband has had pneumonia since December 2021 that will not respond to antibiotics. He gets a little better, then relapses about a week after coming off of antibiotics. He has had testing for the cause of pneumonia and it's bacterial. Can his inability to get well be caused by the CLL?
That's a fantastic question. It's something maybe I should have covered at the very beginning. So the answer is definitely yes for CLL, and is probably yes for nearly all of the lymphomas that I discussed today. So we know that with CLL in particular, one of the things that can be associated with it is a low level of immunoglobulin, and that low level of immunoglobulin can lead individuals to be more susceptible to the development of pneumonias and sinusitis and other diseases, bacterial diseases. And so it is important for supplementing that immunoglobulin on occasion for people who have multiple infections. Likewise, we've also seen that patients with the lymphomas are sometimes less responsive to vaccination and have worse outcomes when they developed COVID-19. It is important that all patients get vaccinated and to get boosters for COVID-19 and to be able to monitor individuals closely and to provide additional therapies to help to address COVID-19 when it's diagnosed in patients with lymphomas.
Hey, thank you so much, Dr. Flowers, for answering all of our questions today. And thank you again to each of you for joining us on today's call. And we hope you found the information both informative and hopeful. We'd also like to thank our sponsors again, AstraZeneca, Pharmacyclics, and Seattle Genetics, for making this program possible. Please do remember, if you have any additional questions or if you'd like to be connected with someone else who's been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. And also, at the conclusion of the program, you'll receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments to complete this brief evaluation, as they are so important for helping LRF to ensure they deliver the most useful and meaningful programming to you. But with that, thank you again, Dr. Flowers, for coming on our program today.
Great. Well, thanks so much. It's been my great pleasure.
All right. Thank you, everyone. Take care. Have a wonderful day.